Hello everyone, welcome to our Mind Matters webinar series. I am Dr. Anjum Ara. I'm a board certified psychiatrist. I work at NeuroDiagnostic Institute in Indianapolis. I work on forensic unit, and most of the patients that I see have diagnosis of schizophrenia. And today the topic of my presentation is understanding schizophrenia. So, schizophrenia is a serious mental illness that affects a person's thinking, perception, and behaviors. It's a biological brain illness that likely starts in utero, and during teenage and adolescence, people start having problems in different areas of brain functioning. And as these people they get older, the deficits worsen, leading to characteristic episodes of psychosis. And it may become difficult for these patients to participate in normal everyday activities like interpersonal relationships, self care, and work. So, as far as epidemiology is concerned, lifetime prevalence of schizophrenia is 1%. Males and females are equally affected. The onset of symptoms occur at different ages in males and females. So, peak onset in males occur at age 15 to 25. In females, they have two peaks. So, one is at age 25 to 35, and the other peak is when they are in their between 45 to 50 years. As I said, in males, the peak onset is 15 to 25 years, but that does not mean that males, they cannot have schizophrenia at an older age. Sometimes we have patients, they have their first psychotic break when they are in their late 30s or 40s, and it's called late onset schizophrenia. So a patient with the diagnosis of schizophrenia, he can go through different stages of illness, like premorbid, prodromal, psychotic, and stable phase. In premorbid stage, the patients have they function normal. They may have mild impairments. And then in prodromal stage, most of the time, the symptoms are mood and anxiety symptoms. Patient can also have changes in sleep, appetite, and declining functioning in school or work. And then the next phase is psychotic phase. In psychotic phase, patients have florid psychotic symptoms. They may experience auditory visual hallucinations, delusions, and paranoia. As the psychotic phase is resolved, the patients enter into stable phase. In stable phase, most of the symptoms are negative symptoms like amotivation, anhedonia, social and cognitive deficits. Let's look at this slide. So this is a slide which explains the natural history of schizophrenia. So you can see in this slide that the premorbid phase, it is most common in childhood, and then the prodromal phase, it's seen in adolescence and young adulthood, and then psychotic phase, it is seen in young adulthood, and once they are older, they are in stable phase. As I said, the stable phase is when they have social and cognitive deficits, and psychotic symptoms are resolved most of the time in stable phase. So this is one more slide. You can see that these are the potential risk factors of schizophrenia. We're going to talk about these in detail. So what is the etiology of schizophrenia? What causes schizophrenia? So the specific etiology of schizophrenia is unknown. Different factors are thought to contribute to the illness, like genetic factors. Genetic studies strongly suggest a link between different genes and the development of the schizophrenia, though no single gene is implicated. People are likely going to have schizophrenia if someone in the family has it. So the risk of inheritance is, as we already talked, in general population, the prevalence is 1%. If someone has a family member like uncles, aunts, grandparents with schizophrenia, the risk doubles. Then the risk is going to be 2%. And similarly, if someone has a single parent with schizophrenia, the risk is 13%. And if someone has both parents with schizophrenia, the risk is going to be 40%. With siblings, biological sibling, the risk is 9%, and with half sibling, the risk is 6%. And in the same way, in monozygotic twins, since 100% genes are shared, the risk is 47%. And in dizygotic twins, the risk is 17%. What are some of the environmental risk factors? So birth in winter months, influenza in the mother during pregnancy, which explains why birth in winter months is a risk factor because influenza infection is more common in winter months. And then exposure to lead during fetal development, major maternal stressors in pregnancy, and then advanced maternal age. We know that advanced maternal age is a factor for Down syndrome. So in the same way, advanced maternal age is a risk factor for schizophrenia. And then people who live in urban areas are at risk for having schizophrenia. And then exposure to viruses like herpes and cytomegaloviruses. Numerous studies have shown that chronic use of cannabis increases the risk of schizophrenia. Similarly, chronic use of amphetamine and cocaine can also increase the risk of developing schizophrenia. The other risk factors are brain structure and functioning. Differences in brain structure, functioning, and interaction among neurotransmitters may contribute to schizophrenia. So patients with schizophrenia, their ventricles are enlarged, they have their temporal lobe volume is reduced, they have deficits in their dorsolateral prefrontal cortex. And brain changes during puberty may trigger psychotic episodes in vulnerable people. So, what are the different neurotransmitters that are involved in schizophrenia? The different neurotransmitters are dopamine, serotonin, GABA, and glutamate. Dopamine metabolism hypothesis is like there is dopamine hyperactivity, which is supported by the medications that we use, antipsychotics to treat schizophrenia. They block D2 receptors, which are dopaminic receptors, which supports the dopaminergic hyperactivity hypothesis. And drugs that increase dopamine cause psychosis like amphetamine and PCP. Similarly, atypical antipsychotics have potent serotonergic activity. GABA, which is an inhibitory neurotransmitter, loss of GABA cells in hippocampus can also cause psychosis. And then PCP and ketamine, they are glutamate antagonists, and glutamate is an NMDA receptor, which explains that there can be several pathways involved. So this is a slide of brain showing dopamine pathways. So I'm not going to go into details, but we will talk about, there are like 4 major pathways, mesolimbic, mesocortical, and nigrostriatal, tubular, infundibular. Mesolimbic pathway is, there is hyperactivity of dopamine, which can cause psychosis, and then mesocortical is, in mesocortical pathways, there is decreased dopamine, which is responsible for causing negative symptoms in schizophrenia. And then in nigrostriatal pathway, because of the dopamine blockade, patients can have extrapyramidal side effects. So what are the symptoms of schizophrenia? The symptoms of schizophrenia can be divided into 3 broad categories: psychotic symptoms, negative symptoms, and cognitive symptoms. Psychotic symptoms are altered perceptions, behaviors, delusions, and thought disorder. So altered perceptions are like hallucinations and illusions. So what are hallucinations? Hallucination is the perception of something in the absence of external stimuli. And the most prevalent hallucinations are auditory and visual, but patients with schizophrenia, they can also have tactile and gustatory hallucinations. And then illusions. Illusions is a misperception based on an actual external stimuli. Patients with diagnosed schizophrenia, they may perceive rope as in snake. That's an illusion. And then next, behaviors. Patients with schizophrenia, they can present with bizarre, disorganized behavior. Sometimes with patients with schizophrenia, they become very violent, and sometimes patients may become catatonic. Delusions are firmly held false beliefs which are not part of the cultural system. It's very important that we know that what might be not accepted in one culture may be normal in some other cultures. The delusions, they persist despite contradicting evidence. And the different types of delusions are persecutory, where patients, they are fixated that someone is out to get them, hurt them, and that people are spying on them with cameras. And then Patients can have delusions of grandiosity where they believe that they are God, they are Jesus, they own this world, they have special powers, or they are wealthy. Patient can also have somatic delusions where they feel that something is wrong with them despite all the labs are normal, CT, MRI is normal, they are fixated, no, they have something wrong going on. And some females have this delusion that they are pregnant despite the pregnancy test is normal. And patient can also have they believe that television, internet, or radio are broadcasting special messages that require some kind of response. So the next is thought disorder. Patients with schizophrenia have disorganized illogical thought process. So we normal patients who doesn't have schizophrenia, our thought process like logical, linear, goal directed. But patients with schizophrenia, as I said, they have disorganized thought process. Some of the examples of disorganized thought process are circumstantiality, tangentiality, loose associations, flight of ideas, word salad. So patients, they can have circumstantiality, which is like their thoughts are connected, but they go off topic before coming back to the original topic. Same way, tangentiality is like their thoughts are still connected, they go off topic, but they never return to the original topic. Similarly, patients may have like word salad. Word salad is like these patients, they use real words when they talk, but the sentence is nonsensical. It does not make any sense. And patients with schizophrenia also perseverate a lot. They repeat the same word or sentence over and over again. So, negative symptoms. So, the negative symptoms of schizophrenia are amotivation, reduced motivation. These patients, they have difficulty planning, beginning, or sustaining activities. And then anhedonia. They don't enjoy the routine. They have diminished feeling of pleasure in everyday life. Sometimes they would go days without taking shower, changing clothes. So those are negative symptoms. And then social withdrawal, difficulty showing emotions. They have flat affect, reduced expressions of emotions where facial expressions or voice tone. Then cognitive symptoms. Patients with schizophrenia have difficulty in attention, concentration, memory. And these cognitive symptoms may interfere with activities like following conversation, learning new things, and remembering appointments. And the cognitive symptoms may also interfere with making decisions that are important for patients. As far as the management is concerned, a lot of studies have shown that the outcome is very good when the medications are combined with psychosocial interventions. So we have the medication that we have to treat schizophrenia are first generation antipsychotics, second generation antipsychotic. So first generation antipsychotics are called typical because they're the first ones, they're older ones, and second generations are called atypical. First generation antipsychotics, they block more dopamine receptor, and they also block serotonin receptors, but they block it as the dopamine is more. So more dopamine side effects. Second generation antipsychotic, they block both dopamine and serotonin receptors, and the side effects are more metabolic, like weight gain, diabetes, hyperlipidemia. So we have long-acting injectables in both first generation and second generations for the patients with compliant issue. And those long-acting injectables are every 2 weeks, every 4 weeks, or every 12 weeks. So we have clozapine, which is called the father of all antipsychotics, and it's the only FDA-approved medication that is approved for treatment-resistant schizophrenia. According to APA guidelines, if the patient fails 2 trials of antipsychotic medications, they are candidate for clozapine trial. So clozapine is also FDA approved for chronic suicidality in patients with schizophrenia. But it is very important to know that for clozapine, the blood work we require blood work. The patients, when we start patients on clozapine, CBC with diff is checked, and it is very important to check absolute neutrophil count. And after that, we check blood work for ANC every week for the first 6 months, then every other week for the next 6 months, and then monthly if all ANC results are adequate. So now what is treatment-resistant schizophrenia? If a patient has persistent psychotic symptoms despite 2 or more trials of antipsychotic medication, then the patient is called treatment-resistant schizophrenia. And it is the positive symptoms that is generally the defining feature of treatment-resistant schizophrenia, even though patients may have persistent cognitive and negative symptoms too. And up to 34% of the patients have this treatment-resistant schizophrenia. The only FDA-approved medication for treatment-resistant schizophrenia is clozapine. But even with clozapine therapy, only 60% of the patients, they do not respond well to clozapine. And these patients are called ultra treatment-resistant schizophrenia. And it has been shown that ECT has been helpful in some of the patients who have ultra treatment-resistant schizophrenia. So let's look at this slide. This slide is about treatment-resistant schizophrenia. So patients are treated with first-line antipsychotic medication with adequate dose, duration, and adherence. And if there is no response, it is possible treatment-resistant schizophrenia. And then second trial of first-line antipsychotic medication is used, same adequate dose, duration, and adherence. If the patient fails, it is treatment-resistant. Then it is confirmed that it is treatment-resistant schizophrenia. Then we give clozapine. We use trial of clozapine. If the patient fails clozapine, then we say that patients are clozapine-resistant, treatment-resistant schizophrenia. And then ECT is found to be useful in some of the patients with clozapine treatment-resistant schizophrenia. So as I said, psychosocial interventions in combination with medications are very, very helpful, and outcome is better. So we have So2 Community Treatment, cognitive behavior therapy, family intervention, social skill training, and supportive employment. So the So2 Community Treatment is where the patients, they have case manager who see them weekly, daily, or every other week or monthly based on the severity of symptoms. They see the patients in the neighborhoods, in their homes, or at their work. They make sure that patients are doing their daily tasks, they are taking their medication, and they make sure that they are going to their appointments and they are compliant with their long-acting shots. And they work 24 hours 7, the case managers in So2 treatment community. And the cognitive behavior therapy, once the patient's psychotic symptoms are resolved, cognitive behavior therapy has been seen helpful. And family interventions, it is very important that we educate family about the diagnosis, the symptoms to prevent relapse. And then social skill training and supportive employment is helpful for patients with schizophrenia. So what are the challenges in the treatment of schizophrenias? The biggest challenge is patients' poor insight. Patients, they don't see themselves mentally ill. So because of the deficits in cortical function, that leads to unawareness of the illness, unawareness of the need of the medication, lack of motivation. And patients with schizophrenia, they have cognitive problems that make dealing with the complexity of the healthcare system difficult. So assuring uninterrupted continuous treatment with medication is also the biggest challenge. As I said, these patients, they don't see themselves as mentally ill. So this is a table that shows the specific factors that influence adherence. So patient, treatment, environment, and social. So patient himself, because of his poor insight, patients fear that the antipsychotic medications are going to cause side effects. And then cognitive deficits and co-occurring substance abuse if they are using alcohol, cocaine, or other drugs, amphetamines. And belief that medication is no longer needed. Most of the time, patients, when they are hospitalized, they become better. As soon as they leave the hospital, they feel that they are doing they're doing better and they don't need to be on medications anymore. So the treatment, it's the complexity of the treatment. Sometimes the patients, they don't respond to medications, so partial or lack of efficacy. As I said, they don't respond to treatment. They have still psychotic symptoms. And then environmental is the practical problems like lack of transportation to go to the appointments, or financial issues. Patients, they don't have enough money to buy medications. And then lack of daily routines and stigma towards mental illness and medication. And then social lack of family support, beliefs of significant others towards mental illness and medication. You can see from this slide that the biggest barrier to medication adherence in patients with schizophrenia is stigma. It's the stigma that they don't want to be on mental health medications. So with this slide, I'm going to conclude my today's presentation on understanding schizophrenia. I would like to thank everyone for participating in today's installment of Mind Matters. And my special thanks to our superintendent, Matt Foster, and our medical director, Dr. Megan, for being an inspiration behind this webinar series. And I would also like to thank McPhee Justin for making all the arrangements today. Thank you so much, and I hope the rest of the day goes good.